Hello, welcome to a brand new medical surgical lesson. My name is Jessie Wheatley and I'll be facilitating this lesson. Please be sure that you have your accompanying notes with you, your textbook ready, and something to write with so that you can follow along with this lesson. Thank you for listening in to this lesson. This lesson focuses on the RN care of problems patients encounter in regards to the peripheral vascular system. With peripheral blood vessel disease or damage, arterial blood flow is impaired, resulting in ischemia, necrosis, and cell death to the tissues. By the end of this lesson, you should be able to understand that peripheral vascular disorders or any other disorders that damage or disease the extremities affect oxygenation and perfusion to organs and can cause life and limb-threatening complications. You should be able to identify clinical assessment findings relevant to each disease process discussed in this lesson. You need to be able to teach patients regarding actions on how to maintain health and well-being when diagnosed with vascular problems. This is a very quick review of diseases that you may have covered in a previous medical surgical class. Let's begin talking about arteriosclerosis and atherosclerosis. Arteriosclerosis, if you remember, is the thickening or hardening of the arterial wall that is often associated with aging. Atherosclerosis is Atherosclerosis, on the other hand, involves the formation of plaque within the arterial walls and is the leading contributor to cardiovascular disease. Through the process of cellular proliferation, collagen migrates over the fatty streak, forming fibrous plaque in atherosclerotic changes. These plaques are either stable or unstable, and unstable plaques are prone to rupture and are often clinically silent until they rupture. And factors such as abnormal lipid levels, injuries from toxins, genetic predisposition, diabetes have a major effect on the development of atherosclerosis. What do? When you're assessing the patient with atherosclerosis, you want to include a complete cardiovascular assessment because associated heart risks are often present in these patients. People with multiple risk factors are grouped into a high risk patient category. Uh, that's called coronary disease equivalence. So I have that in your notes. Coronary disease, heart disease equivalents. These groups include patients with diabetes but without symptoms of vascular disease, patients with a Framingham heart study 10-year absolute score of over 20%. I have a link available for you in my notes for you to be able to visit to see how this is scored. Patients with identified with multiple metabolic risk factors, people within these groups are as at risk at the same risk level as those that already have vascular disease. Interventions for patients with atherosclerosis or those that are high risk for disease focus on lifestyle changes in avoiding or minimizing modifiable risk factors. If you remember, we talked about modifiable risk factors, and the nurse is going to play a big role in teaching the patient to make sure that they're able to modify those risk factors. You want to assess the patient for modifiable and non-modifiable risk factors for vascular disease, and you want to teach health promotion behaviors to the patient and family. Pay particular attention to the patient with a family history of cardiovascular disease. And we talked about the modifiable risk factors as those that can be changed, controlled by patients, such as smoking, weight management, and exercise. Remember that risk factors such as smoking increase the pathophysiological process of atherosclerosis, as in this picture here. In collaboration with a nutritionist, this patient should be taught to incorporate healthy eating to lower cholesterol and saturated fats and increase fresh fruits and vegetables and fiber in their diet. Those that do not respond adequately to dietary interventions, we're going to prescribe them one or more lipid-lowering agents or serum lipids. I have included a reference for you in your notes is for you to be able to look at all the drug classes in such as HMG CoA reductase inhibitors, which are called statins, and other lipid-lowering drugs. You will need to know these drugs and how they work. And I've included a page for you to access that. Let us now take a moment to review hypertension. Hypertension is a systolic blood pressure greater than or equal to 140 millimeters of mercury, or diastolic greater than equal to 90 millimeters of mercury. This is how it is printed in your textbook. Essential hypertension is called primary hypertension, and it is not caused by another health problem or drug. It's primary hypertension. Secondary or non-essential hypertension is caused by other problems or health problems or drug therapy. The classification in less than 80 millimeters of mercury the classification for normal adult blood pressure is 120 over 80. Adults with a blood pressure of 120 to 139 or 80 to 89 diastolic are classified as prehypertensives. These are the recommendations in your textbooks for updated recommendations nurses must follow. The most up-to-date Joint National Committee report, the JNC 8 link, is provided in your textbook. Be sure to stay up to date to the most up-to-date recommendations for treatment of hypertension. The textbook also talks about malignant hypertension, which is a severe elevated blood pressure that is rapidly progressing. A person with health problems usually has symptoms such as morning headaches, blurred vision, dyspnea, symptoms of uremia. Delayed treatment may lead to renal failure. So just like this picture, I've told you hypertension affects the kidney, the brain, and the heart. That's what you're more worried about. It also can lead to left ventricular failure and a stroke. So hypertension is essential or primary most of the time. Isolated systolic hypertension is a major health threat, especially for older adults in the U.S. As people age, the systolic blood pressure becomes more significant, and because it is a better indicator than the diastolic blood pressure for risk of heart disease and stroke. Diastolic blood pressure rises until age 55 and then it declines, whereas systolic blood pressure continues to rise. Isolated systolic hypertension is defined as a systolic blood pressure reading at or above 140 with a diastolic blood pressure below 90. Research demonstrates a significant association between isolated systolic hypertension and peripheral vascular disease. I've included some risk factors for hypertension. I've also included a link for you to see the examples of drug therapy to treat hypertension. It's very important that you visit my notes and study a little bit more about that and make sure that you understand the drugs therapy for hypertension. Diuretics, calcium channel blockers, angiotensin converting enzyme inhibitors, and aldosterone receptor antagonists are going to be used to treat that. There are newer calcium channel blocker that I talked about in your notes. For patients who are prehypertensive, they may also benefit from a low-dose daily aspirin. We know once-a-day drug therapy is best, especially for older adults, than taking several doses a day. Be sure to visit my notes and be sure to review hypertension. Let's now talk about peripheral vascular disease. It occurs as a disorder that alters the natural flow of blood flow through the peripheral arteries and veins, especially in the lower extremities, as shown in the picture. Most patients are not diagnosed with peripheral vascular disease until they develop leg pain. Most patients initially seek medication for a characteristic of leg pain called intermittent claudication. They may have some cramping and burning sensation when they can only walk certain distances before they start having that, before it forces them to stop. You want to recognize the clinical manifestations of peripheral vascular disease depend on whether it affects the arteries or the veins. I have notes that talk about the tests and the treatment for the chronic disease in your notes, and I also talk about the procedure atherectomy to improve the blood flow to the extremities that may be used, um, and that's also in your notes. Now let's talk about acute arterial occlusions. These may be sudden or undramatic, usually caused by an embolus from a recent acute MI or an AFib. Those with acute arterial insufficiency often present with the 6Ps of ischemia: pain, pallor, pulselessness, paresthesia, paralysis, and poikilothermia. Anticoagulant therapy with and fractionated heparin is usually the first intervention. A surgical procedure or thrombectomy or embolectomy will follow, with local anesthesia may also be performed. Compartment syndrome can happen when tissue pressure within a confined body space becomes elevated and restricts blood flow. You're familiar with that, so the nurse is going to have to make sure that they're doing their neurovascular assessments and the charting of the 6Ps. The resulting ischemia can lead to tissue death and damage and eventually cause a lot of problems. Watch these patients, guys. Let's quickly take a moment to review an aneurysms of the central arteries. An aneurysm is a permanent localized dilation of an artery. Aneurysms happen at specific anatomical sites, mostly commonly in the abdominal aorta. An abdominal aortic aneurysm, or a triple A, account for most aneurysms and commonly asymptomatic and frequently rupture. The thoracic aortic aneurysms are not as common and are frequently misdiagnosed. Atherosclerotic changes is the most common cause of aneurysms, with hypertension and hyperlipidemia, cigarette smoking, and a family history are contributing factors. Patients with a rupturing aneurysm are critically ill, and hemorrhagic shock is the biggest risk there. Monitor for indications of rupture such as diaphoresis, nausea, vomiting, pallor, hypotension, tachycardia, severe pain, and decreased level of consciousness, or a pulsating abdominal mass. You want to avoid palpating the mass to avoid rupture. The eggshell appearance of an aneurysm on an abdominal or lateral x-ray is essentially diagnostic, but CT may assess the size and location of where it's at. The goal of non-surgical management is to monitor the growth of the aneurysm and maintain blood pressure at a normal level to decrease the risk of rupture. Surgical management of an aneurysm may be elective or an emergency procedure. Aneurysms can also happen in the peripheral arteries. Although femoral and popliteal aneurysms are not common, they're often associated with an aneurysm in another location of the arterial tree. The patient may have symptoms of limb ischemia, a decreased blood flow, or they may have poor absent pulses, cold skin, pain, and the recommended treatment for aneurysms, regardless of size, is surgery because of the risk of thromboembolic complications. Aortic dissection is thought to be caused by a sudden tear in the aortic intima, opening the way for blood to enter the aortic wall, as in the picture here. A common symptom is pain that is described as a tearing, a ripping, and a stabbing. It tends to move from its point of origin. Chest x-ray and CT and MRI and aortic angiography may be used to confirm the diagnosis, but an MRI may be too slow. Patients receiving continued medical treatment, such as controlled hypertension or uncomplicated distal dissections, and surgical treatment for proximal dissections may be recommended. Buerger's disease is a relatively uncommon occlusive disease limited to the median and small arteries and veins, usually identified in young adults who smoke. Your textbook goes in a little bit more detail than that, but it's pretty uncommon. But there's a picture of Buerger's disease. Subclavian steal is going to happen in the upper extremities from a subclavian artery occlusion or stenosis, resulting in altered blood flow and ischemia in an arm. In your arm. The surgery is recommended interventions for cyanosis or pain there's a severe occlusion or stenosis of the subclavian artery that's causing problems. Thoracic outlet syndrome is a compression of the subclavian artery at the thoracic outlet by an anatomical structure such as a rib or a muscle. So collaborative care includes PT, exercises, and avoiding aggravating positions such as elevating your arms. Surgical management is used with severe pain or loss of hand function or poor response, or involves resection of the anatomical structure that is compressing the artery. Let's now review Raynaud's phenomena. As shown in the picture, it is caused by vasospasms of the arterioles in arteries of the upper and lower extremities, often occurring with associated systemic connective tissue disease such as lupus or systemic sclerosis. If not alleviated by drugs, a lumbar sympathectomy may be performed to relieve that, but that's what the patient's symptoms are going to look like. In popliteal entrapment causes ischemic symptoms in the affected leg or foot because of anatomical compression of the popliteal artery back here in the back of the leg. The recommended management is surgical repair of the anatomic compression. Let's now review venous diseases that cause blood to back up into the distal areas and can lead to edema and thrombosis that can become emboli or life-threatening complications. These are peripheral venous diseases. The first one you want to talk about is venous thromboembolism or DVT. It refers to a deep vein thrombosis or pulmonary embolism with symptoms of tenderness and pain. Or it may be asymptomatic. Deep vein thrombosis is the most common type of peripheral vascular problem. When symptoms are present, there's swelling, as you can see. There's redness going on and warmth. Preferred diagnostic test is a venous Doppler ultrasound, which is non-invasive to rule out DVTs. It is most often treated medically using a combination of rest, drug therapy such as anticoagulants, and preventative measures. The RN should closely observe the patient receiving anticoagulants and to make sure that the patient is okay. Another peripheral vascular problem would be venous insufficiency. In venous insufficiency, there occurs as a result of prolonged venous hypertension with results from edema, venous stasis, ulcers, swelling, and cellulitis. Treatment is chronic venous insufficiency is primarily non-surgical unless the patient has had complications. And then, of course, the notes include pointers on varicose veins, phlebitis, and vascular trauma. Please be sure to review those, okay? Thank you. Thank you for listening into this lesson. I hope you have enjoyed this quick review of the RN nursing care for patients with peripheral vascular diseases. You want to remember to plan for the patient with atherosclerosis and hypertension in collaboration with the healthcare team to include a nutritionist and a pharmacist as needed. You want to reduce the risk of injury, caution patients about orthostatic hypotension when they're taking antihypertensive drugs. In collaboration with a nutritionist, you want to assist patients to incorporate healthy eating behaviors to lower cholesterol and saturated fats and increase fresh fruits and vegetables and fiber in their diet. For overweight patients, you want to assist them with a weight reduction plan. You want to closely observe the patient receiving anticoagulants or thrombolytics for for signs of bleeding, and monitor appropriate lab values for desired outcome values. You want to monitor decreased serum potassium levels when patients are taking thiazide or loop diuretics. You want to teach patients to move slowly when changing positions if they're taking any of the antihypertensive drugs. You want to teach patients to take statins to patients taking statins to lower cholesterol to report any adverse effects, especially muscle cramping, to their healthcare provider. You want to monitor the patient's liver enzymes carefully if they're on statins as well. Thank you so much, and if you have any questions about this lesson or the corresponding notes, please feel free to email me. Have a lovely day.